Excellent. So now we have to all be good. So any other questions for the palm tree team about those 3 studies? Okay, if not, we'll jump in with Dr. Phyllis Ritchie, who is a well-known and beloved provider here in the desert. She was at DAP for many years and now is struck out on her own. So we'll welcome Dr. Ritchie and let her tell us about what she's been up to. So welcome.
Oh, thanks, Jeff. That's so nice of you. I have been in the desert for a while. I was at DAP for about 6.5 years. And I noticed that the new HIV infection rate and the new STI rates, chlamydia, syphilis, and gonorrhea, during my time at DAP kept going up. And it was shocking because there's all these various interventions in Palm Springs for STIs, STI clinics, et cetera, get tested Coachella Valley. And but it didn't make a dent in the STI infection rates in Riverside and Coachella Valley. So I decided to start a clinic where I would get rid of a barrier that I felt prohibited people from getting tested and treated, including HIV tested. And so I opened a free STI test and treat, and it's called PS Test. We've been open since July, and we basically do free HIV STI testing and treatment. Again, we opened in July, and immediately when we opened, we found two new HIV infections and initiated rapid treatment and linked them to care within 48 hours. So, and then have had multiple various STIs, gonorrhea, chlamydia. I've read a lot, and I think that people weren't getting tested during the pandemic, afraid to go to the doctor's office. Naturally, I was afraid to go to the doctor's office. So, anyway, we're getting busier, and I really enjoy it. We give out, we start people on PrEP and link them to care as well. We're not a long-term clinic. We're simply STI test and treat. And we rapid HIV test and rapid Hep C test as well. So that's what I've been up to. This is more freestyle interaction between HARP and me. So I'm hoping there's questions. I do want to mention that the guidelines for STI treatment have changed. They changed last December. So it's almost December again, but December 2020, they changed where there's a higher dose of ceftriaxone for treatment of gonorrhea now, and azithromycin is gone. So I'm not sure if everyone's familiar with the treatment regimens for various STIs, but azithromycin is gone, and it's simply ceftriaxone for gonorrhea, and we switched to doxycycline for chlamydia. So things have changed slightly, and we're very fortunate to have rapid treatment in our clinic, so we can start new HIV patients, the same day on medication and link them to care. So that's where I am. I'm on Toshiba doing that, and I am wondering if anyone has any questions for me. I've been doing HIV for a long time. Since the beginning. I gave a lecture today to Foothill AIDS Project on HIV 101, and I had to think back about when I started doing HIV, which is about 20 some odd years ago, when it was a different story than it is now. People basically at that time, when I was a resident, maybe it was 25 years ago. Anyway, I can't think about it. People came into the hospital with HIV diagnoses to die, and now people are then in my lecture today was people are just living with HIV as a chronic disease, similar to diabetes or hypertension. But anyway, you guys all know that, and I was hoping we'd have a form of didactic, and if anyone has any questions or comments, I was hoping that's how this time would go.
Thank you, Dr. Ritchie, and thank you for all your work over the years and for opening up this new clinic. So just to be clear, so it's the testing and treatment are free to anybody regardless of their insurance status, or how does that work?
Yeah, so our clinic is completely free. You know, you can have no money or $1 million. It's going to be free. We don't check it. Well, we check insurance just because it's on our electronic record, but we don't take it. We don't charge it. We don't do anything with it. It's just, you know, the CDC lately, because all over the United States, the STI rates are getting really bad. The CDC has gone into this, and STI clinics have closed because there's no money. They closed over COVID. And so the CDC has come out with a statement recently saying that they would like these STI clinics to be almost like fast food, and you go in, you go out. You don't fill out a lot of paperwork, and that's what we're striving to do with PS Test. It's in and out, and actually, you know, that's how people feel. It's in and out. No fuss, no muss, no exchange of money, and very little paperwork to fill out. So what was your question? Did I answer your question?
You did. I was asking if it was both testing and treatment were free for anyone, regardless of insurance.
Yeah.
Great. That's good to know, because you're right, that model is kind of going away, and people are expected to go to their doctors, but people don't always have a regular doctor, and we have a transient population, the people who are, you know, moving here or visiting. So
yes, we're getting a lot of visitors. We're getting definitely a lot of visitors to our clinic, for sure. A lot of travelers, a lot of out-of-state people Googling us and coming in, and it's great. We're actually going to be at Pride if anyone wants to stop by and get a water bottle.
we'll look at the festival then.
Yeah, we'll be by Marilyn Monroe.
Oh, perfect.
Yeah. Yeah, we're happy with what we're doing. Not that this is that medically interesting, but I did snag Matt Moran, who was a nurse. I don't know if everybody knows him, but he was a wonderful nurse practitioner at Desert AIDS Project, and wasn't sure he really wanted to go back to work, but I forced him into it. And so he's working with us now, and it's just a great team of people. So, you know, it's good. So anyway, let me open it up to you guys. And do you have any comments or questions about STIs or HIV or anything on those lines? I'm free to answer anything. So
go ahead, Andrew. I see your hand went up.
Thank you. Yeah. Well, first of all, I really want to thank you for doing what you're doing. As you all know, STI rates in this area are astronomical. And I was very upset that Eisenhower dropped their STI testing here. So I was very pleased when actually John Colbert there told me about your new clinic. I have looked at your website, and it's wonderful that what you're doing and able to provide it for free. As a sidelight, I'm just kind of curious. I saw you taking donations. What kind of budget, or how you managing the finances of this? Just out of curiosity, before we get to political things.
So we expect a grant to come in from the county soon. They've okayed it. This is all new to me, but they've okayed it, but I haven't seen any money yet. So hopefully that'll happen soon. And then so far, it's actually me and my husband that have been supporting this. 100, well, not 100%. We get some really generous donations from patients and neighbors and friends, and that's been, I had a patient that came in from, I think, Canada. They were visiting, I don't remember, I think they were visiting a friend, and graduate students at Tulane University, and really didn't have much money whatsoever, and left. And next thing I know, I had a PayPal donation of $25. It almost made me cry. It was so kind. So donations, my husband are doing the bulk of it, but friends, neighbors, and patients right now. Yeah.
Okay.
Yeah.
You know, one of the things, it's been a couple years back, but I know DAP was for a long time had this huge campaign about, you know, get tested, you know, for HIV. And I was like, get tested for STIs is what, you know, what also needs to be out there. I don't know what you can do personally, but is there a way to get, you know, just more people tested? How can one promote that issue and get more people in to your office or any other place that's tested in around this area? Because as we know, it's just huge.
Yeah, it's huge. I mean, we took out an ad on Spanish radio, so, and that brought people in, you know, I've been on, I have an ad out in KGay, and then I was on another radio station. So, you know, slowly, I think it's word of mouth, quite frankly. Slowly we're getting busier and busier. And you're right, STIs are really important. You know, I know that there's a campaign to have home testing for HIV, but I just think that you're right, STI testing should be really pushed in this area, because as you know, syphilis and gonorrhea, HIV travels right along with them. And so it's just, you know, it's part of sexual health. In fact, I was talking to, I don't know if you're familiar with Coachella Valley Volunteers in Medicine. It's a free clinic up in, is it Indio? I was up there. I don't know where I was.
Yeah.
I think it's, you know, talking to the executive director, Doug Morin, who I totally admire and really respect and like. And you know, he wants to do a sexual health clinic. So somehow maybe we'll collaborate. But it's just an important part of life, you know, for everybody. And I was reading the other day that the only way, I don't know what I was reading, but it was so antiquated. The only way to prevent HIV and STIs is to be abstinent. And I was like, what? That's so unusual. Who's, you know, so it's just part of life. Sex is part of life. And that's what we preach at PS Test, and you know, no shame, no guilt, no judgment. That's so I don't know. I think it's word of mouth. I think it's word of mouth.
Okay, well, thank you. When you talked about the changing treatment on the gonorrhea.
Yeah.
So to remind me what the medications were again. I know the second one was doxycycline, I believe. Yeah.
So so it's interesting. Before December 2021, the United States, the CDC recommended ceftriaxone 250 milligrams, which is an intramuscular injection, along with azithromycin. And the thought was the azithromycin and the ceftriaxone together would help cure ceftriaxone. But quite frankly, no other country was doing that. Most countries, Canada included, and we sure get a lot of Canadians here, were giving 500 milligrams intramuscular of ceftriaxone. So finally, I mean, it really took a long time, but finally the CDC, you know, took it up a notch, I should say, and changed the recommendations to 500 milligrams intramuscular of ceftriaxone. So doubled the dose, basically. Got rid of the azithromycin because who knows if that was doing anything really, and it just probably causing resistance in patients. And then so that's gonorrhea. The doxycycline is for chlamydia treatment.
Okay.
So,
and if one is allergic to doxycycline,
probably go to azithromycin, which also could treat doxycycline as well.
Okay.
Yeah.
Yeah. And I know that the guidelines for people with HIV and getting treated for syphilis is 3 sets of shots now. But I recently read a paper online that indicated that 3 shots may not be a necessary thing. What is your awareness of that?
So HIV positive or negative, it actually is treated the same. So, you know, it's a complicated, syphilis is complicated, that's for sure. But there's primary, secondary, and tertiary syphilis. And primary is basically a chancre or a sore on the penis or that vagina, and it's painless. And that would be primary, and that's 1 shot. Secondary has been there, you know, but less than 2 years. We know when they got it, and that's 1 shot. But if it's an unknown syphilis where, geez, you know, I don't know when I got it, or you know, it's more than a year, then that would be 3 shots 1 week apart. There was, sorry. Oh, there was a problem with syphilis a few years back in Palm Springs in particular, but it was all over. But it was a blindness, a temporary blindness associated with syphilis. You know, I remember a patient calling me and saying, geez, I can't see. It was totally reversible, but the syphilis test was positive, and sent him to the eye doctor, the ophthalmologist, and they could actually tell that it was syphilis, and you'd get an RPO, which is a syphilis test, and it'd be positive. And that would require 2 weeks of intravenous penicillin, and that was a totally different case. And that was considered tertiary syphilis. So when you know, HIV positive patients can potentially be more prone to neurosyphilis, and that's also 2 weeks of intravenous penicillin. But quite frankly, I haven't seen that in a long time with the new HIV medications. So that's syphilis in a nutshell. HIV positive and negative are basically treated the same.
Very good. Thank you so much.
Yeah, sure, no problem.
Thank you for your work. I think it's tremendous what you're doing. Thank you.
Thank you. Does anyone else have any questions about sexually transmitted infections or HIV or hepatitis C? We also test rapid test for Hep C as well. You know, there's been a lot of patients recently in my clinic who are HIV positive, undetectable viral loads, and you know, probably aren't as careful as they could be, but come in and get tested. And so there's been a lot of gonorrhea. We've seen a lot of gonorrhea lately. I don't know, that could change all of a sudden to chlamydia or syphilis, but if, you know, so there is sometimes there's a feeling that even though you're undetectable equals not transmittable, as we all know, there's not transmittable of other sexually transmitted infections, just FYI, that you probably all know that anyway. But anyway, so that is a good point to make.
Speaking of gonorrhea, we're hearing a lot about resistance, and I know there was a study a few years back, I think in conjunction with DAP, where they were looking at an alternative medication for gonorrhea. So can you speak to the rates of resistance here and what that means for people coming in to get tested and treated?
Yeah, so in the area, in the United States, the resistance levels, so that study you're talking about, Jeff, is actually the same study. It's just a later version of the DAP study. It's a topoisomerase. Yeah, and so it's actually it's really a great study. The resistance in Riverside County isn't really high, and the resistance in the United States isn't that high either, but we're seeing cases. I mean, we're seeing below 10% nationally, but we are starting to see cases, and so that's the concern. And there's more cases that are in Canada, and again, that's our neighbor. So you know, we really have to, so we're worried. We're worried that ceftriaxone just won't work eventually. And what do we do there? And so that's the other point is we just need to bring the levels down. But the resistant levels aren't that high yet, but they'll get there. Believe me.
So are there any recommendations for that to prevent that from happening? Do they suggest people start on a different one, or they want to preserve the older ones as long as possible before?
They're the old ones as long as possible.
Yeah.
Yeah, so they're, you know, if you look up the CDC guidelines, there aren't that many great alternatives right now, except for this one that Palm Tree is studying is a really good possibility, but it's hard in HIV patients with the protease inhibitors and the non-nukes. So, but in the HIV negative patients, it really is a good solid alternative. And what we do need is more studies to look at alternatives to ceftriaxone for gonorrhea.
Mhm.
It's important, yeah. Does anyone else have any other questions regarding STIs or HIV or anything like that?
What are you finding about the Hep C rates here in the area currently? I don't hear about it as much lately, but I know it's been an issue.
Yeah, it's still an issue. You know, it is transmitted sexually and intravenous drug abuse, and it's transmitted more when there's possible tears in skin. So anally sexually active can be more of a way of getting hepatitis C, intravenous drug abuse, and it's rising. I mean, it's one of the it's an potential STI / IV drug abuse infection, and definitely again rising. That so this grant that we're getting is we're getting 2 grants from the county. One's in the epidemic and the HIV epidemic area, and one's also a Hep C grant, because those 2 infections are on the rise in the county, and we're just trying, you know, we need to bring that down. So both of them are on the rise. Yeah, so we do need to bring those down.
Well, yeah, thank you for taking on Hep C as well, because I know, you know, often Andrew was talking about the DAP's Get Tested program, and, you know, that was, and unfortunately it's the money that dictates how this gets done, and the monies for that were a CDC grant specifically for HIV, so they couldn't do HCV and things, although it makes sense, right? STDs are STDs, it doesn't matter what they are, and as Dr. Ritchie said, they tend to travel together. Be fellow travelers, so it really makes sense to be doing this way. So what for the hepatitis C, are you able to provide a full course of treatment then if someone tests positive?
No, we're not. I mean, if someone tests positive, and we haven't had any positive Hep C, so which is good. But if someone tests positive, what we would do is link them to care within a rapid amount of time. It wouldn't have to necessarily be as fast as HIV linkage to care, which is, we strive to do 48 to 72 hours, but it would be fast. We would either send them, depending on, there's where the insurance comes in, depending on what kind of insurance, whether we could send them to, well, I either send them to Dr. Del Rosario Borrego or GAP, you know, whichever one they want to go to. But Dr. Del Rosario is just so convenient. He's, you know, down the block. So, but again, that's when the insurance would come in.
Mm-hmm. And then for HIV, are you able to do the rapid start and start people right away so they're on meds before they're looking for care, or how does that work?
Yeah, we start them on usually start them on Biktarvy, you know, same day. We have it in our office, generously donate to us, and or we can start them on Simtusa. if we don't have the Biktarvy available. I do like Biktarvy. It just seems really well tolerated and easy to take. So we start them on, so the patients that we've had that turned out to be HIV positive, we started on Biktarvy. And if they have a doctor, we just send them back to their doctor that they already had. So one fellow was on PrEP. I'm not sure how well he was taking it. And we started him on Biktarvy and sent him back to his PrEP physician that he was already seeing. And then the other fellow, we started on Biktarvy and sent him to Kaiser. He was a Kaiser patient. Yeah, but again, we'd probably send them to depending on their insurance, where they could go and talk to them about it. But you definitely need to link them to care within 48, 72 hours. And then also we would get all the HIV tests right away as well, CD4, viral load, et cetera, and resistance testing as well. So yeah, so we do all that.
Great. So Raymond has a question in the chat asking if HIV is on the rise.
Oh yeah. So I just, interestingly enough, I was taken aback because I just looked at Riverside County statistics, and people living with HIV in Riverside County has doubled since 2015. And I didn't know whether that was necessarily new infections or people moving here, because it was just people living with HIV. So I looked into it a little more, and it's new infections. Those are new infections, doubled since 2015. It really blew me away, and that's Riverside County. So we're part of that, obviously.
Yeah, do you have any sense if that's the case here in the Valley? Because often what's happening countywide doesn't always reflect what happens in our little bubble here. And
yeah, so it's interesting because the age range was also there. What the age range of the new people living with HIV, and it was older. I mean, it was 60. I think it was 60 to 69 was the highest age range, and nationally, it's under the highest population of age is under 30 in the United States right now. So I thought to myself that perhaps Palm Springs was bringing, that age group up because, we are an older city. So I don't know. It's a really good question. I don't have the actual stats for Palm Springs itself, but Riverside County, 60 to 69 of people living with HIV, white cisgender men. So just to make clear that we're all knowing the definition of cisgender, not to belittle anyone, but cisgender means a person born as a man and identifies as a male. So white cisgender males are the highest number of those people living with HIV in Riverside County. So I really do think that perhaps Palm Springs is bringing that rate up. I just have to believe that.
mm-hmm. Yeah, it makes sense. So.
Yeah, but that was a good question. That was a really good question. Any other questions for me?
Yeah, feel free to unmute yourself or use the raise hand feature, or if that's not working for you, you can always post it in the chat as others have. We don't always get a chance to have this kind of free-form discussion with one of our doctors, so please take advantage of it. One question I had is, we were talking about the high rates of syphilis here, and it always has been a hotspot.
Yeah.
And, I hear with COVID, all that's gotten worse because people weren't getting tested. They didn't stop having sex, even though I guess they stayed home and with a friend or two or three. But what are your thoughts on syphilis prophylaxis? I know the late Dr. Scheibel was a big proponent of this, and so for people who would come in with repeat STIs, he just put them on doxycycline and keep them on it to prevent both syphilis and chlamydia. So I was just wondering what your thoughts were.
Yeah, no, I think it's a good idea. I'm actually, it's funny you bring it up. I'm tossing it around in my head how to go about it, because did you send me this article or did I just read it about actually not being on a regular dose of doxycycline, but taking it right before sexual activity and right afterwards. So kind of like that antiretroviral PrEP. I don't know if you remember that from France a few years back, where you take the PrEP before and right after.
PrEP on demand, yeah.
So actually, this is doxycycline on demand, really. And actually, so I'm debating in my mind how to offer that. And I kind of like the idea of not having to take it every day. And I'll tell you why, Jeff, because of the issues of resistance. And doxycycline right now is one of the best oral drugs we have besides Bactrim for methicillin-resistant staph aureus infections. And it concerns me, geez, and I can't tell you how much I thought of Steve Scheibel. I thought he's one of the smartest, most wonderful people I've ever met in my life, besides my husband. But but so I like this idea of doxy before and after sex. I think it's smart, and I need to read that article, and I think I might be offering that instead of every day. I like it.
Now, how would that work then? How many days before and how many days after? Is it the same as Truvada for on-demand PrEP, or?
I'm going to send you the article because I can't quite remember, but I think it's like right before. I'm pretty sure it's right before. I don't think it's a few days before. So it's much easier regimen than anything else. It's just, I think it's right before, but I can't remember. And I'll go back to it and I'll send you the article. It's really, I liked it a lot. It sounded like a good idea. And I don't know, taking another pill, pill fatigue always comes up, pill fatigue, especially with HIV positive patients, and, taking one more medication, or anyone really, HIV positive or negative, taking one more medication is just, one more drag. So unless, I don't know, I'll send you the article. I'm tossing around in my mind how to handle that.
I have read that article. I believe it was in The Body. It may have been on thebody.com, but it may be published somewhere else and also put there. But I did read about that. I know our Timothy H was quoted in it as one of the people. But yes, the article is out there and the information is out there. I think it's an interesting idea. Like you, I'm concerned about the resistance that can come from ongoing antibiotic taking.
Yeah, I mean, it's a problem. If we keep doing, we'll run out of antibiotics. I'm an infectious disease specialist that's my training. So you really worry about further and further resistance, as it's same with the resistance with antiretroviral medications as well. You worry about resistance with that. So yeah, totally agree.
So go ahead.
Everything Steve Scheibel did, I have to say, was wonderful. So
yeah, no, he was well loved and he's much missed. I think what we need to do is co-formulate Truvada, doxycycline, and maybe Viagra in one pill, and then you could get people to take it right before sex.
That's a great idea. Let's write an article about that.
Let's do the study.
All right.
Roll that quickly.
Well, given the issue of resistance, particularly that we know of gonorrhea currently, from what I've heard in terms of the pharmaceutical industry, they're not really interested in developing new antibiotics. Do you know if that research is going on? I mean, it seems to me that there's a need that should be fulfilled by the pharmaceutical industry. There's not no money in it, but I've heard the argument that there's no money in it, and I can't believe there's not any money in it. And the same thing, is there any regarding syphilis, is there any other development in helping to rid syphilis? I know we were getting into that point some time back.
So the reason there's no money in it is ceftriaxone is a really cheap drug. So I'm happy when the medical assistants, my medical assistants say to me, hey, Dr. Ritchie, we need more ceftriaxone. I'm like, oh yeah, great, no problem. But when they say to me, we need more bicillin for syphilis, I'm like, oh God, because it's, so to give you an idea, a dose of bicillin is about $300 and a dose of ceftriaxone's about, I think it's about $5. So there's no money in it. But good news is there's a new study out recently looking at an oral antibiotic for syphilis. It's a cephalosporin. It's similar to ceftriaxone. And so that would be syphilis. As far as gonorrhea is concerned, I don't know of many, but the one at Palm Tree Clinical is a great option. I haven't, it's a little bit of a difficult study just because I'm getting all sorts of patients, but the bulk are gay males, and the study at Palm Tree Clinical is a wonderful study, but they do want only urethral gonorrhea, not anal or throat. So I mean, I could give, there's so many patients with anal and throat gonorrhea. So that's the only problem with that study. But it is a great study because there aren't that many out there. You're right, there isn't that much money in it. It's pathetic. There's more money in COVID, I mean, obviously. So yeah, not a lot going on, unfortunately.
Yeah, I know. I mean, a decade or so ago, they were close to eliminating syphilis in the US, and then it came roaring back with a vengeance. It speaks to the problems with their healthcare system.
Yeah.
And the public
Don't have medical
and
homes.
the public healthcare system.
Yeah.
Yeah, so today, again, I was giving this lecture at Foothill AIDS Project, and it was mostly to social workers, and I think a few psychologists, but one of the psychologists spoke up and said that he has patients that are HIV positive that aren't on HIV medication. And I was really taken aback. He questioned his patients, and they said, yeah, my doctor said that I have to be at a certain viral load in order to start HIV medication. And I said, well, that's just abhorrent. So, I mean, if that's happening, then imagine people even talking about sexual activity and, how to prevent it. I think that, I think even these days in 2021, there's many healthcare providers that don't want to talk about sex and don't feel comfortable. So that's a problem. Yeah.
Well, you were speaking about the increasing rates of new HIV and older people, and that's why. You heard about it all the time. You talk to older people, and it's like, well, my doctor refuses to ask me about sex. Somebody's over 60, to a young doctor, it feels like you're asking your mom or your grandmother, if they're sexually active, and counseling them on prevention. And it makes people really uncomfortable. And it should just be a routine part of all medical visits.
Yeah.
If you take the blood pressure, things like that, you ask if somebody's sexually active, and they are, and you just proactively treat them. I know a lot of the HIV treating providers here for all their patients, positive or negative, every time they come in, I know my doctor tests me for syphilis. He doesn't ask me, what my risks were. If I'm sexually active, then he takes the blood test and does the swabs, and is proactive that way. And that's what everybody should be doing. But unfortunately, it's not. You'd think with the FQHCs and so forth, they could, have guidelines for that and make that a routine part of care, and at least in those systems.
Yeah. Well, I mean, at least even talk about PrEP or things like that. But just two quick stories. I remember when I was just it'd be a third year medical student. So really fresh, really green. And I was in the emergency room doing a rotation, and there was a woman, a young Chinese woman, having severe nausea and vomiting. And I thought, oh, what's wrong? What's wrong with her? I couldn't figure it out. I got an x-ray of her abdomen, and they would let us do anything. I was at Cook County, so they let us do anything without any observation. But in the end, the last thing I thought about in this young Asian woman who looked, very, very prim and proper, but she was pregnant. And didn't even cross my mind. So that was a lesson I took home. And, everybody has sex. So that was one lesson. And then the other lesson was this 75-year-old woman that came in to my practice when I was practicing, my own practice, HIV. I was in a big practice in Chicago, 75, didn't feel well, flu-like symptoms. And, I thought, well, I'll check HIV. And sure enough, she was HIV positive. She had sex, she was in a assisted living, and assisted living people are sexually active as well. So she was a new HIV patient. So I always keep these things in my mind because everybody's sexually active.
Yeah, anybody who's ever worked in a nursing home knows that there's
Yeah.
still people interested in sex there. It
Very
doesn't go away.
No.
Great. Other questions for Dr. Ritchie? Well, I've run out of questions. Is there anything you wanted to share with the group, or any kind of feedback you wanted to get from?
Yeah. Well, I was just wondering what kind of regimens people are on, and how they're tolerating them. It's the regimens have gotten so much easier since I first started, and how things have changed for everybody with the HIV regimens.
I see your hand up, Christopher. Go ahead.
Hi, Dr. Ritchie. Thank you for being here.
Hi.
And yeah, my regimen has gone down to Tivicay and Descovy, which were really the only two things I was sensitive to, but have for 5 years kept me undetectable. So it feels so simple, and I do have to take an antidiarrheal pretty regularly in a small dose, just because this seems to still not allow my system to have regular bowel movements. It's always still loose. So, but I don't have any food interaction or negative interaction with food or other things in that regard. And with the Descovy, when I have missed, I know that it does go up into the bloodstream quickly again when I get back on it. So, and sometimes it's just like a one-off missed dose.
I mean, I don't know if you remember the days when people had to carry around the little ice coolers with them, but I do. So the regimens have just gotten so much easier and so much more well tolerated. Yeah, I think that's great. I think with any chronic medication regimen, the possibility of chronic diarrhea is there no matter what it is, whether it's HIV medication or not. So, it's still a lot better than it used to be, though. And I think it's great. I think 2 drugs is great. I think 2 drugs is pretty much here to stay. 2 drugs, maybe 1 drug.
What is your advice about looking at the injectables and switching to that? Because I understand you have to first go on one of them, you go to a pill and then to the injectable. What if it's not working and you have to go back? What is your view on that.
Yeah, you're talking about cabotegravir, I think, and I think it's worth a try. It seems like a really good medication. I've read about it, and the resistance is pretty low. It's very low. I mean, there isn't any resistance as far as I know right now. Have you been offered cabotegravir, or it's cabotegravir and rilpivirine?
Cabenuva, it's called. Putting it in the chat.
I've not been offered it, but I know that it's available in trials, and
Yeah.
and I've
Yeah.
been hearing about it. I'm just, I consider that for myself. My regimen is so routine. I'm almost unconscious of having to take my pills, but then I still have to take them. So
Yeah.
I'm just
Yeah.
asking.
Yeah. I think it's a good option. I mean, I don't see any downside. I mean, and this isn't really medically speaking, this is just me as a person speaking. So don't quote me in the desert sun or anything. But I remember there was a medication for I'm blanking on what it was. It was a long time ago. It was at Cook County. I forget what disease it was associated with HIV, but it was a once a month injection. It was a once a month injection, and everyone thought, oh, great, and it turned out that it was pretty toxic. And since you got the injection already, it was really hard to get rid of it, and it was there for months. So that's my only stutter on anything that's more than every day. If it were me, personally, I'd stick with what I know and it's working. And again, this is just me talking. I'm not giving you any, I don't want to be quoted. But if it was me, I probably, I'm just a comfortable person, and I like to do what's comfortable for me, and I would stick with what I know. And if my levels are undetectable and you don't mind taking the drugs and you have a little diarrhea, that's how I would approach it. Yeah.
And doctor, the other thing that occurs to me is just when patients are continually getting syphilis and gonorrhea, and they're with partners, either repeat partners or new ones, what is it that they're not seeing? What signs or symptoms on the other patient are we not seeing that might expose it? If we were looking and seeing this, that we might not expose ourselves. Or I think back to, high school sex class, and trying to picture what's the drip. It's like, is that what we look for? I know, like, if I see a rash or if I see a chancre, you know not to go there. So, but it has to be beyond that what we're missing.
So you're talking about if you're going to be sexually active with someone else or on yourself? With
someone else. And when I was more active and a young man, I would always suggest a shower. It was like kind of nice, you're cleaning each other up, you explore each other's body. And that was my whole purpose. I wanted to look to see, what's there. Has he got an athlete's foot, So it just occurred to me, maybe, and that routine may not be happening, and other people exploring each other's bodies. Like, do we need to take more time when we're with a new partner? It's like, what is there advice for that?
Unfortunately, with gonorrhea and chlamydia, there's not a whole lot of symptoms for the other person to look for. I mean, in fact, a lot of patients will come in and say, hey, I was told that I got exposed to gonorrhea, and I have no symptoms. And so I'll treat them, and sure enough, they have gonorrhea. But sometimes there's, the slightest symptom of pain upon urination, dysuria we call it. But for you to look for in someone else, or not you, but somebody to look for in someone else for gonorrhea and chlamydia, there's really not a whole lot to see. And even syphilis, a lot of times, if you miss that chancre, or they don't have a rash, there's really not much to see either. So that's why people need to get tested, because there's really just, not much, period. I mean, there could be a rash, but there couldn't be, there could be a sore, but there doesn't have to be. I mean, even with herpes, herpes, a lot of people don't have painful ulcers. And still they can give you herpes because they're still shedding the virus. Interestingly, that was a big lawsuit recently. In the past 5 years in San Francisco. But anyway, so symptoms aren't necessarily very helpful, unfortunately. I wish they were, but they're not. They're most of these are silent infections, and that's how things are passed around. But taking a shower is really good. Yeah, if you see a chancre, that would be a sign. Oh, I better watch out.
Thank you.
Well, I think now that people meet on the internet, they're getting down to business quicker than they might otherwise. It's all those negotiations happen online, right? So once they get there, then
that's true. 2021, there are no showers.
Enter Nathan.
That's a good question, though. I don't know what to think about cabotegravir. I think it's probably a good drug, but I'd stick with what I know. That's just my own personal feeling.
Well, a couple of things about cabotegravir, or Cabenuva is the brand name of the combination of Cabenuva with rilpivirine or ezurance. So what they do is precisely because of the issue we're talking about, people respond badly, with an injection, it's in your system for a month. They actually have you start on oral pills for a month. So before you start the injections, you take the pills for a month,
right,
for precisely that reason. So that way you know if how it works for you before you do it. But what I'm hearing is not everybody's offering it because of the challenges in doing the injections. You can't just go to Walgreens and get a shot in the arm. It's a shot in the butt. And it's not just a regular shot in the butt, like a testosterone shot. They have to use a special technique. They call it a Z-track injection. They put it in, inject a little bit, move it around because the volume of what they're injecting is so high. And it's 2 shots, 1 in each cheek. So
I didn't know that.
Yeah. So, and I know Eisenhower hasn't figured out how to kind of incorporate that into its clinical practice. So I don't believe they're offering it. I don't know what. Is anyone here on it or know of anyone who is locally?
No, I hadn't known. I hadn't known it was 2 shots. The description is always, oh, it's just a shot a month. So the details are left out.
Yeah, but that's a huge volume. Both of them are a big volume.
No idea.
Yeah, I didn't know that either. That's really interesting. Is DEP offering it, you guys?
Anybody know?
No,
I have no idea.
I've only heard of it like through Palm Tree or other that are testing right now. It's just going through the final phase of approval, isn't it, Jeff?
Which one's that?
But Jeff said it was approved in January.
Yeah, Cabenuva has been approved for a while.
This is Gary. Dr. Morris recommended against Cabenuva for me a couple of months ago. We'll see if he's changed his opinion when I see him in 2 weeks, but I don't think it was based on anything specific, just not wanting to make a fast move, that's all.
Yeah, I mean, probably saying the same thing that I'm saying, that, if your regimens, so he's older than I am. So you're talking to old time practitioners, and, if something's working and there aren't too many side effects and you're undetectable, Yahoo, you've got, and so you know, you probably want to stay the course.
And then there's a lot of other long-acting drugs in the pipeline. Gilead, of course, has one. They always let everybody else take the risks, and then they come in with a new drug, clean up on the market. But this one is called capivavirine, or the encapavir, and so that's going to be an oral you can take, and I think they're looking at injections as well, but it'll be a long-lasting drug for at least a month, if not more, orally.
You said lenacapavir, is that what you said?
Yeah.
Yeah, they're going to look at that for PrEP, from what I understand too. I think it's once a month. Injection once a month. Yeah. So yeah, these long-acting drugs are in the pipeline. You know, the big thing is, and it's, you know, quite frankly, that's where the money is, are all these drugs for HIV and nothing for STIs. But the big question is when are we going to have a vaccine? That's the bigger question, and you know, and you know, really end the epidemic, in my opinion.
Yeah, well, I've been positive since at least 1992, and I didn't go on medications till 95. And I've certainly been through assorted regimens, but I have, for the last 6 years, I've been on Icentris and Evotaz, and been doing fine with that. And like what you're saying, I wouldn't choose to switch to the injectable, because I'm very used to taking my pills every day. So it's not really a problem, I feel, because it's just, I can do it. And so, like you say, if it's working, I'm going to keep it.
Yeah.
That's my feeling for me at this point. So yeah.
Yeah, no, totally agree. Totally agree. Any other question? Any other comments?
When you were talking about an HIV vaccine, and you know, they're looking at the mRNA vaccine platform that Moderna and Pfizer both used for the COVID vaccine.
Yeah.
And the reason that happened so quickly is because they had been looking at it for an HIV vaccine for a long time. So they stopped their HIV trials, but everything was up and running, and they were immediately able to pivot to COVID, and that's why those were the first two out of the gate. And you know, and still look like the best ones on the market. So that's really encouraging. So yeah, you can be sure that they're going to go back and revisit HIV. But whether that would be, you know, a one shot for chronically infected folks like us, or, you know, a preventive vaccine remains to be seen. Probably a preventive vaccine to start. And,
yeah, I don't know though, Jeff. I mean, my girlfriend who does research at Stanford, she thinks that actually it will be for chronic people too. So I don't know if it will be for preventative first. I'm not sure about that. But she seems to think that it'll really rev up the immune system. So I don't know. We'll have to wait and see.
well, a little bit of a teaser for HARP is that we're going to be working with a newly funded NIH collaboratory that does cure research based out of Scripps Institute in La Jolla and USC. It's called RID HIV, for reversing immune deficiency. And they're looking at, and all of the collaboratories looking at this now. There are currently 10 that are funded, and they're groups of researchers and pharma representatives from across the country and around the world. I know our group has at least 2 people in Europe, as well as here, and a lot of the others have people all over. But they're looking at what they call combinatorial approaches. So combining a vaccine with a broadly neutralizing antibodies and maybe a drug that kind of kick awake the resting cells and so forth, the so-called kick and kill. So they're looking at kind of putting all this stuff together in kind of a kitchen sink approach, but, you know, combination therapy, because that's worked for, you know, the pills with HIV that work so well for us now. And then, you know, the immune system is a really complicated animal, so they're looking at kind of poking and prodding in different ways to find it to do what it can't do on its own. So yeah, we'll see. This is really exciting stuff. But HARP is going to be involved with that, and we're going to have an annual cure symposium hosted here in the desert each fall in conjunction with the science meeting that has been happening here for years. So you'll get to hear more. We'll be doing that in honor of Timothy Ray Brown. And our first speaker is going to be his successor, the so-called London patient, a guy named Adam Castillejo, who went through the same procedure Timothy did. And to date is the only person who's actually survived and been cured of HIV along with Timothy. So I'm happy to be doing that. Exciting stuff.
So will the meeting take place this year or start next year?
Next year.
Oh, wow, that
Yeah.
is really,
Yeah, I mean, with COVID, we can't do it. They were thinking about doing it in the spring, but it was still uncertain. So they pushed it back to the fall. So it looks like we'll do it every year in the fall, around that first part of October.
wow, great, congratulations. That's a big deal.
Yeah, we're excited.
Yeah, cool.
The NIH has been funding these collaboratories for 10 years now, and this is the third cycle. So it's another 5-year cycle of funding. So, you know, they're getting closer. It's an incremental process. And now everybody wants a cure yesterday, but, you know, it's taken a long time, and it's, you know, a complicated issue. If it was simple, we'd have it by now.
Yeah.
In the meantime, we're learning a lot, and it's paying off with COVID and other diseases. So
Yeah,
it's
that's
plugging away.
yeah.
It worked for Hep C, right? It was protease inhibitors that were the first drugs to cure Hep C, and that's all because of HIV research. So
Yeah. Excellent. I'll be looking forward to those meetings.
Any other questions or comments people would like to bring up? We've got another 15 minutes if people want to use it. Well, if not, thank you so much, Dr. Ritchie, for taking the time and bumping up the month.
Jeff, I had one comment. Jeff, this is Gary and Dr. Ritchie. So I don't know if anyone else was at the Cabenuva presentation last week. It was close to an hour and it was very informing, but you know, it's not as easy as it sounds, unfortunately. It's, first of all, 2 shots, as some expressed surprise. And I did find out it's from a very small needle, maybe a 28 or 30 or some such size. So it's not like the old penicillin injections for syphilis. But you have a 7-day window on either side of the 30-day re-injection time. But you know, if you're away for a couple of weeks, I don't know. I think doctors' offices are almost pretty much always open for these kind of routine procedures. But during COVID last year, I get my pills delivered, whereas the injection might have been sort of tough to arrange. Yeah, there's a regimen of, I think, pills for a month before you start the Cabenuva. And anyway, I take so many pills, including over the counter, that actually I realized that won't change my medication regimen much, just like Christopher said, I think. It's twice a day, once in the morning at 8 and once in the evening around 8. And, you know, so that I'm not surprised Dr. Morris said, let's wait. Let's be very careful and think about this carefully.
Yeah, it makes sense to me. I mean, as we all age, I mean, I'm really into, so I'm into Western and Eastern medicine. So you know, my husband takes all these, I don't know, he's turmeric and things like that. And because of me, I say, oh, you need turmeric, you know? And so he's taking about 10 extra pills a day. And so I was, because of all these, you know, turmeric's like 3 pills by itself. So, you know, as we age, you know, everyone is taking more and more pills, and it's just becoming kind of a natural sort of, unfortunately, natural sort of thing. So yeah, you kind of get used to it, and you take your pills in the morning and boom, you're off the day. So yeah, I agree with you. I don't know if I don't know what to say, but I think that if you're happy with your regimen, stick with your regimen. And that's just my recommendation, but.
Well, it's the drug companies that are driving this because they talk to, people who've just gotten HIV and they're freaking out having to take one pill once a day. So
Yeah.
oh my God, we need to lower the pill burden. But, as everybody's been saying, we've been taking these pills for 30 or 40 years, some of us. And, it's no big deal. You get used to it. And we're taking, as we get older, our blood pressure medications and, everything else for old age stuff. So it's not like you're not taking pills. And, one or two more isn't going to make the difference. And trying to convince drug companies of that, especially for the chronically affected population, it's like, if you come up with a new drug that you can't make, they say it has to be druggable. It has to be in a pill. You take once a day. And it's like, no, twice a day is fine for a lot of people. There's a market for that. It may not be as big, and, give it some time and you'll figure out how to make that pill smaller once a day or whatever, or an injectable. But you're always trying to convince them not to leave something on the shelf just because they can't immediately make it, one pill once a day or less now. That the bar just keeps going up. Now it's once a month and every 6 months, and it'll be once a year. It's just, we hope they don't leave drugs behind that could help people just because it doesn't fit their marketing paradigm.
No, I totally agree. It's like PrEP too. They're once a month, and they're going to look at. I heard about preparation that's like a birth control. They injected in the arm, and I forget what they call it. Anyway, for every 6 months. So, one pill once a day or two pills once or twice a day. I mean, my opinion isn't at the end of the world. And you're right, Jeff. At least you're not carrying around that little cooler with you anymore and worrying about that ache and things like that.
Yeah, I was glad I never had to do Norvir as a liquid. I took Norvir in the pill form, but I'd heard about the liquid form, and I was glad I never had to do that. But I think you're right, Jeff. It's convenience of people who are newly infected. They want that convenience of a once a month. But from my perspective, as we've just talked about, I just think this whole thing of having to go to the doctor's office and getting the shots can be cumbersome. Whereas I've got my pills at home and I take them when I take them. So my only problem is because I have one pill is 2 a day, is I can sometimes miss or not get the early second pill at the right time, but I get them in.
No, makes sense. I mean, I remember the kidney stones was it Indinavir with the kidney stones?
Yeah.
I've been through that. Yeah.
Treated patients through a lot of badness. So I don't know, if you're happy with your regimen, I say stick with it. The HIV has been through too many toxicities, quite frankly. And another thing you have to remember is, like I said before, the highest population of new HIV infections nationally is under 30. So that's the other thing, is everyone, the young people want things now and fast and not have to worry about things. So that's probably maybe another driving force of the once a month regimens. Who knows? Yeah.
Well, I think also in, other parts of the world where people trouble getting access to clean water and stuff, and, bringing them back to the clinic every 6 months, A, you need to see them, and B, that's when they get their injections. It's a good thing. But then, of course, it's going to be a challenge of, can people keep those schedules? It's doing things once a day, you get in the habit, but if it's, once every month or 2 months or 6 months, are people going to remember it and come in the window that they need to be seen, and, not be off meds.
Yeah, that's true.
The brave new world, we'll find out.
We'll find out, it's true.
Great. This has been terrific. Any other questions or comments for Dr. Ritchie or the group?
I do have to say that I'm really excited about this new peripheral neuropathy study Palm Tree Clinical is doing, because I mean, quite frankly, I've been doing HIV for 1,000 years and haven't really heard of anything new on the pipeline for peripheral neuropathy. So to have something potential is quite exciting.
Yeah, I hear people complain about that all the time, and it's like they've just gotten used to it, but it's
Yeah.
an ongoing problem for a lot of old timers.
Yeah. Yeah. So anyway, thanks for having me, Jeff.
Great, thank you for joining us. We appreciate it.
Yeah, I hope we can do it again.
Absolutely. Anytime you want to come back, you just let us know.
I will. Thanks.
Yep, thanks so much. Thank you, doctor.
Nice to
Thank
see
you a lot.
Thank you, everyone.
Good night.
Good evening.
Bye.
Thank you.
Good night.
Bye.